Good morning, everyone. As part of just a second. Very good morning to everyone. So, as part of the deciphering the ECG, a basic module brought to everyone by the Department of Medicine, Ramaya Medical College. Today, we'll be having a discussion of a revision of all the concepts that we have understood over the past two sessions. So I would request some of the volunteers to volunteer to answer these cases. So these are actual cases that have been seen in so many years. I would start with a quote that is very famous. So remain all the time steadfast in the heart, for God will determine the future for you to accomplish the work. What is to be done will be done at the proper time. Do not worry and abide in the heart. So we'll abide in the heart and try to understand more about the heart. So any volunteers, please raise your hand or unmute yourself and we can start off the discussion. So there are about 10 cases and the forms have been sent previously to everyone. Any volunteers, you can volunteer for the case and we'll discuss it case by case and we'll understand the approach to how we decipher the ECGs. Is my audio clear? Am I audible to everyone? You can put it in the chat. Okay, if there are no takers, I'll start off with the first one. So this is an ECG of a person who came presented with breathlessness. So whenever you are seeing this, whenever you have a breathlessness and a patient coming with breathlessness, so we have a few differential in our mind. So one could be a cardiac cause, a respiratory cause, a neuromuscular cause, and so on based on the time course of the illness. So what are we seeing in this ECG? So we are seeing some low voltage complexes in all the leads. So first we look at the standardization, which is normal. So once the standardization is normal, we look for P waves. So P wave is upright in 2, 3 and negative in lead AVR and positive in V4, V5, V6 and most of the other leads. So with this we say it is first, we come to the conclusion that it is a normal sinus rhythm. And the A/V or atrium to ventricle conduction is 1:1. For every P wave there is 1 QRS. For every P wave there is 1 QRS. So once we know it is a normal sinus rhythm, so we try to look at the rate. So the RR intervals are regular mostly. So if we take this, it would be 300, 150, 100, 75. So the heart rate is somewhere around 75 beats per minute. After that, we look at the intervals. We come to the intervals, which is PR looks okay. The QT is okay, it comes exactly midway between the two RR intervals. So these two intervals are okay. And coming to the axis, there is lead 1, which is positive, lead AVF, which is also positive. But very peculiar is in this ECG that there is low voltage complexes. So this low voltage complexes, you can hardly see lead 1, you can hardly see any R waves in any of the leads. So even in the precordial leads, it is very, very minimal. So this is what we call as a low voltage complex. This low voltage complex, how do we define a low voltage complex is? For a low voltage complex, in the limb leads, the amplitude should be less than 5 millimeter and less than 10 millimeter in the precordial leads. So if this is present, then we call it as low voltage complexes. So what can cause a low voltage complex? So if this is my heart, so this is my pericardial cavity that is there here. And let's say this is the electrode that I have placed. So this is going to be my lung here and a pleural reflection here. So anything that is going to impair the flow of current from the heart till the electrode can cause low voltage complexes. So one is I can have fluid in the pericardial cavity, or I can have gross air trapping or expansion of the lung, which can be in emphysema, or there can be this pleura that can be filled with fluid, or there can be fat which can make the patient obese. So these are the things that are going to impair the flow of current. Apart from that, there can be a problem at the level of the muscle itself. So there can be loss of the muscle in the heart, or there can be infiltration of the muscle. So thereby it can cause some deposition of some abnormal proteins, and that can cause low voltage complexes. So these are the possible causes for a low voltage complex. So one of the most common causes that we see is whenever you see such low voltage complexes, always think of mixed edema if the patient clinical background fits. So this is one of the most common reversible causes. Apart from that, we'll have effusion, etc. But mixed edema has to be remembered and worked up for. So the diagnosis here in this patient, so this patient underwent a biopsy and found to have a systemic amyloidosis. So this is the recap of whatever we have discussed. So low voltage complexes definition. So we can have fluid, fat, or air. So infiltrative disease, mixed edema. So in infiltrative disease, very important is amyloidosis, sarcoidosis, and hemochromatosis. Apart from that, if there is loss of myocardium, even then you can get this. Then there is one drug called as tafamidis, which is going to work only in transthyretin-related amyloidosis, wherein it is going to stabilize the amyloid membrane. Anyone volunteering for this ECG? Would you like to try answering live? Like, we'll unmute you, Dr. Z. Faisal, okay, Faisal has answered. Yeah, go ahead, Faisal. Just start interpreting this ECG.
So this is a 12 lead ECG.
Good.
With the normal
next.
Its rate is around 300 divided by 2, around 150, sir.
What would be the rhythm here?
Regular sinus rhythm.
Okay, so you are saying it is sinus. Okay.
Yeah, PR interval is shortened.
Very good.
That ST, yeah, the AVR is negative, sir. So it's lead placements are good.
Okay.
ST depression in lead 1.
Okay.
ST depression in lead 1. AVL.
Okay.
Uh,
You're seeing
AVF show
here. What is this?
this delta wave. So
Okay. Very good. Then
so it's diagnostic of WPW syndrome.
okay. So you're saying it is WPW syndrome. Okay. What about this one here? You're seeing some very large voltages here. So after you have seen the intervals, so what are the axes here? Axis?
1 and AVF. Okay. It's 1 in the positive and AVF in the negative side. So it's left axis.
Okay. So is it physiological or pathological left axis? Lead 2 is positive here. So would it be physiological or it would be pathological? So it will be more than -30 or it will be within 0.
Physiological.
Physiological, correct. So this is physiological because lead 2 is predominantly positive. Very good. But what about here? So once we have seen the intervals axis, so we have to look for chamber enlargement. So is there any chamber enlargement?
Yes, a very tall. Yeah, LVH.
LVH. Okay. What are the criteria we are going to use for LVH? So what criteria is fitting in here for LVH?
The Q in V1 plus R in V5 more than 35 mm.
Plus R in V5 more than 35. Okay. So you're saying this is there. Or isolated R more than 25 in V5 or V6. So definitely it is there. 5, 10, 15, 20, 25. So easily it will come to 25. Okay. So that is one more thing. Okay. Very good. Excellent. Excellent answer. So we'll discuss this now. So that is very important. Very important to remember here is you cannot make a diagnosis of hypertrophy or chamber enlargement whenever you have a pre-excitation syndrome. Okay, so that is one thing you have to remember. So you will have falsely very high voltages that can mimic MI, many things pre-excitation can do. So as Dr. Faisal had said, so we have a normal standardization, a normal sinus rhythm with a regular rate of about, maybe let's say around 90 to 100 beats per minute. But very important is here you are seeing the PR interval which is short. So whenever you have a PR interval that is short, then we look at one more thing here. So you're seeing a slurring and upsloping here. So you can see here in one AVL here. So very clearly it is seen. So as soon as this comes, it just shakes off and then you have a QRS. And very clearly it is seen in V2 as well, in V5, everywhere. So it is seen predominantly everywhere. And also very important is here, you also have to look at the precordial, the inferior lead. So you're seeing here a P wave, and then you're getting a fall like this, and then a QRS. So this is also a delta wave. So this is a negative delta wave. So this upsloping here is called as a delta wave. So this delta wave is not equal to WPW syndrome. So that is one thing we have to remember. So we'll discuss why everything is formed with just one diagram now. Okay, so this is my conduction system. So if my SA node is going to fire from here, so it activates the right atrium, and then it is going to have the left atrial activation as well. At this point, let's say there is one accessory pathway here. So it is a sleeve of connective tissue that is having sodium conduction, which is very quick. So they have a fast conducting sodium channel. Okay, so now what happens is, there is going to be an impulse that is going to arise from here. So as this impulse is coming, spreading everywhere, so it sees that there is this tissue here that is going to be conducting very fast. So it enters the muscle. as it enters the muscle, it is going to activate the muscle. So when it is activating the muscle, we know that myocyte to myocyte conduction is going to be very slow compared to a normal conduction pathway. Okay, so once this is going to happen, so we'll try to imagine. So it is activated a part of my atrium, and then it has to come to the AV node and undergo the delay, but it is not happening. Before that, there is this impulse that has gone off very quickly. So this aberrantly conducted impulse very quickly, which has been conducted. So it enters the muscle and very quickly it is going to activate the muscle and it is going to be a little slow. So it creates a slurring here. And then after this activation here, the normal conduction is going to happen through the normal myocyte or normal conduction pathway. So after that, you're going to get a normal QRS. So this will be the normal QRS. This part is going to be my pre-excitation. So why do we call it pre-excitation? Because it is happening prematurely. Okay, so this pre-excitation is the cause for this delta wave. And normally what happens is there can be some T wave abnormalities. So if the QRS is positive, sometimes the T wave may be inverted. So that can be seen in some pre-excitations. So most important to remember is this point, that just because you have a delta wave, it is not equal to WPW syndrome. So as soon as you see a delta wave, you should just say there is pre-excitation. That's it indicates. If this patient has any symptoms like sudden palpitation, syncope, recurrent syncope, etc., whenever he is symptomatic, only then we call it as WPW syndrome. WPW stands for Wolff, Parkinson and White. Only then it is called as WPW syndrome. Else we don't call it as WPW syndrome. Okay, I hope this is very clear. So very classical. And based on the polarity of the ECG of this delta wave, you can localize the pathway as well. So it is just that for our satisfaction on the surface ECG we will localize, but finally we have to map. There can be more than one accessory pathway, involved. Hence you have to go for finally a electrophysiological study and plan for a radio frequency ablation of that pathway. Okay. So we saw there's a short PR interval, there is a delta wave, positive delta in these leads, negative in the inferior leads. So this has its own localizing value, whether it is an anterior, posterior pathway, whether it is septal, lateral, all this will get based on the delta wave. Okay. So after that ECG, there is this ECG. Anyone willing to take up this? We'll discuss. Okay, if there are no takers, I will take this. So this is again well standardized ECG. We have to look then at the rhythm. So when you're trying to look at the rhythm, whether it is sinus or not sinus. So when we are seeing upright P wave in lead 2, a negative P wave in lead AVR, and positive in most of the leads. So it is sinus in origin. So once we know that, we have to look at the relationship between the atrium and the ventricle. So we see at the PR interval. So this seems to be a little prolonged. But what are the relations? So there seems to be no relation. Then we look at the QRS. The QRS is wide here. So there is a wide QRS. which is more than 3 small squares. After that, the axis coming to the axis here, it is 1 is positive, AVF is negative. So we have with lead 2 being negative, so we have a left axis deviation. So after the axis is done, we come to the chamber enlargements. Before that, so obviously there is no obvious chamber enlargements. Then coming to the QRST changes, PQRST changes. So this is where everything changes. When you're looking at the intervals, we come to the diagnosis, which is classical here. So we are seeing a P wave here. So very obvious P waves we'll mark first. So we are seeing a P wave. So once we are seeing a P wave, so we are seeing some notching here. So normally it is not smooth. So there is one notching here. This could be a P wave. So if you are seeing some P wave at this interval, so at 3 boxes, so again we look at 3, 1, 2, 3. So that means this might be underlying another P wave. So this is another P wave. This is another P wave. So look at the T wave. So it is not smooth. There is one bump here. So this is another P wave. There is this another P wave. So there is P wave that is beating constantly. And the RR interval is also very constant. So the RR is constant, the PP is constant. That means the atria rate is separate, the ventricle rate is separate, and both are beating independent of each other. So this is what we call as an AV dissociation. So whenever we have an AV dissociation, we look at the atrial rate and the ventricular rate. So that is what had been discussed previously, whether you have ventricular tachycardia versus whether it is an advanced AV block. And the PR is variable. So we have PP interval constant, RR interval constant, variable PR intervals. So all this suggests that there is the diagnosis here would be a complete heart block, because the atrial rate is more than the ventricular rate with a advanced AV dissociation. So this is what is complete heart block. So by definition, it means there are 2 pacemakers in the heart, because the atrium has its own pacemaker. For the ventricle, it may be either the AV node or it may be the ventricle itself that is activating the ventricle. So the 2 possibilities here. So here the atrial rate is more than the ventricular rate. So because atria is beating faster than the ventricle, there is complete dissociation at the level of the AV node. So this is classical for a complete heart block. Once we know there is a complete heart block here, we'll try to find if we are finding any etiology. So here we are seeing some QS complexes. So this is called as a QS. There is no R wave. So there is only QS here in all the leads. And there is a nice R wave here in lead 1 as well. So this is a P wave here. So this is an R wave. So we have a R wave in lead 1 and a QS in V1 to V4. So this is suggestive of a left bundle branch. It will be discussed later. So this is suggestive of a left bundle branch block. So, and very important is you are seeing here, these limb leads, all these limb leads have very low voltages. So we are seeing low voltages in the limb leads, and we are seeing somewhat preserved voltages in the precordial leads. In the precordial, it is normal. Here it is low. So a combination of a low voltage in the limb lead plus precordial leads with normal voltages is suggestive of a heart failure. Whenever you have a ejection fraction that is low or an advanced heart failure, so this is what you can see. So heart failure, some of the signs on ECG is a low voltage complex on the limb leads and normal voltages in the precordial leads. So the final diagnosis here is a complete heart block with a heart failure. So we see the ventricular rate, atrial rate regular, so the PP interval, RR interval, which indicate the ventricular rate and the atrial rate. The PR is variable. So there's a wide QRS, so this is because of a left bundle branch block. This is a poor R wave progression, again part of the left bundle branch block. And there is an AV dissociation with atrial rate more than the ventricular rate, suggestive of a complete heart block. So this is one more ECG that is something similar, but there are a lot of observations to be made here. So here again, let's assume the standardization is normal. The P wave is upright again. The P wave is going to be upright in lead 2, 3 and AVF and negative in AVR. So we say it is a normal sinus rhythm. So then we come to the rate rhythm. So coming to the axis, so here we see here there is a physiological left axis deviation that we are seeing here. Apart from that, we come to the chamber enlargement. So we'll come to the rhythm analysis at the end. So chamber enlargements, there is no obvious chamber enlargements that is seen here. For chamber enlargement, we look at two leads. For the atrium, we look at two leads, which is lead V1 and lead 2. For the ventricle, we look at lead V1 and V6. So we'll see there are some ECGs that have some hypertrophies. So there are no chamber enlargements. So here you are seeing a RSR dash pattern in lead V1. Here there is a QS here. So this is what we are seeing. So for any rhythm analysis, it's always better to use this lead 2. There is a long lead 2 that is going to be there. So there will be 13 usually. So 12 plus the rhythm strip. So here we see a P wave here. The P wave here is seen, a P wave is seen here, P wave is seen here. But then there is some blip that is there here. There's one more here. There is one more here. So you have to look what Marriott called. So that means you have to look for the P wave. You have to hunt for the P wave. So they will be usually hiding in the T wave. So here you see exactly at the end of the QRS, there is a P wave here. Again, there is a P wave here. Again, there is one P wave here. Again, a P wave here. Intermittently, there is a capture that is there. Then there is a P wave here. There is a P wave here. There is a P wave here. P wave here. So there is a marching P wave. So and a marching QRS. So this is again suggestive of a complete heart block, where the atrial rate is more than the ventricular rate, and there is a marching QRS. So this is suggestive of a, again complete heart block. Then this is the next ECG we have. Anyone willing to take for this ECG? Anyone volunteering to answer this ECG? Okay. Not be able to answering. Okay, fine. I'll only take this also. Okay, so with this, in this ECG we have, there's a normal sinus rhythm with a normal standardization. So here you can see standardization is normal. And then we are seeing a normal sinus rhythm with evidence by a P wave here, which is normal. The AVR is negative. So these are the first things that we are seeing. Then there is seeming to be a bradycardia here. So what is the heart rate? 300, 150, 100, 75, 60, 50. So the heart rate is 50. So there is a sinus bradycardia. So once we know the rate and the rhythm and the interval, so we have to look at the interval. So we know the rate, we know the rhythm. So coming to the intervals, so we look at the P wave here. We see the P wave here. Here there is a prolongation of the PR interval. There is prolongation of the there is prolongation of the PR interval. Okay, so rightly someone pointed out. So you are seeing the RR here, which is irregular. Okay, we'll try to find out why it is irregular. It will come to it very shortly. So there is only this that is irregular. Otherwise, the ventricular rate is somewhere all right. So this is what we have. So we have a prolonged PR. So this prolonged PR indicates there is a first degree heart block. So there is a first degree heart block. So once there is a first degree heart block, we have to look for other things. So PR is prolonged, the QT looks okay. Then what are the obvious changes that we are seeing? So here you are seeing lead 1 is positive, lead AVF is negative, again lead 2 is negative, suggestive of a left axis deviation. So after this, there is no obvious chamber enlargements. There is no chamber enlargements. Coming to the ST changes. So that is where we have, so there is a poor R wave progression. So first is we look at the P wave, so there is nothing. So we look at the Q waves. So there is a deep Q wave here in lead 3 isolated. In lead 2 there is an RS complex. So that is part of the left axis deviation. Causes for it will be discussed further in subsequent sessions. So here we are having a poor R wave progression here. Apart from that, here you are seeing the RR interval is regular here, but compared to this RR, this is somewhat occurring earlier. So this is called as a premature beat. So what is called as an ectopic impulse that was discussed in the last class. This is an ectopic impulse. So it has come very early in the cycle. So because of that, it is going to prolong the further subsequently, the duration of the action potential subsequently. So the premature atrial complex probably, because there is some abnormal P wave that is seen here. So there is a premature beat. So here you are seeing a normal PR interval. That means it is abnormal because the normal PR interval here is prolonged. So a normal PR interval in the background of abnormal means this is again abnormal. So this is a premature beat that is there, that has activated the ventricles. So we have a left bundle branch block that was there. So this is the QS, the poor R wave progression with the left axis and the tall R wave in one. That is suggestive of a left bundle branch block. So along with that, we have first degree heart block. So whenever we have two parts of the conduction system blocked, so that is called as a bifascicular block. There is also something called as a trifascicular block, wherein you can also have coexisting right bundle branch. So whenever you have a right bundle branch block with either a left anterior or posterior fascicle block with a first degree AV block. So this is what is called as a trifascicular block. So we have this fairly very simple. QRS is wide. There is this. So this is finally a bifascicular block. Coming to this ECG. Anyone wants to take this ECG? This is fairly simple. we'll come to this ECG. This is also a very interesting ECG. So we see a normal standardization, a normal sinus rhythm, or you can put it in the chat what you think is the diagnosis. In case you do not volunteer or decipher the ECG, you can put what you think is the ECG in the chat box. So you can put all your findings, we'll keep discussing. Yeah, good. So lead 1 is positive. So correct, there's a left axis deviation, very good. So Faisal says there is a Mobius type 2, very good. Good. Okay. So keep your comments coming. I'll keep reading it in the chat section. So we have a normal sinus rhythm, normal standardization. So once we see those two, we'll come to the rhythm. So it's done. Coming to the rate. So the rate, there is only one portion that is a little abnormal here. Apart from that, roughly the rate looks all right with 300, 150, 170. So around 60 to 70 beats per minute is the heart rate. So after the rate, so usually the ideal way is to count for 3 seconds and multiply that by 20 to get the heart rate in minutes, in beats per minute. So coming to the intervals. So this is where we have, so in the intervals, so this is where we will get our diagnosis in this ECG. So you look at always whenever you're looking at the intervals or you want to analyze the rhythm, you always go for long lead 2. So here we are seeing a PR interval that is borderline pronounced. So there is the end of the P wave, the onset here. So probably it is just a little more than 5 boxes. So here it is very clear. So you have a P wave here and then there is, so somewhere around 6 to 7 small boxes is where we have the PR interval that is prolonged. So here it is 6, so 6 boxes. So it is mildly prolonged and this is constant. So that means this is very constant and suddenly there is one beat that is dropped. And you look at the PP interval, so that is also occurring very regularly. 1, 2, 3, 4. 1, 2, 3, 4. There are 4 boxes in between each P wave. So exactly at that point, there is one beat missed. And again, it starts off in the similar way. Again, a beat is missed and again, it starts off. Apart from that, so this is suggestive of a Mobius type 2 AV block. So I'm sure we all know this. So whenever you are dealing with heart blocks, so whenever we have type 2 AV block, it is going to be Mobius 1 and Mobius 2. So in 1, there is going to be progressive PR prolongation and a drop beat. Whereas here there will be a prolonged PR, which is going to be constant, and then the beat is going to be dropped. So this is type 2 that is there, Mobius. Apart from that, coming to the axis, so 1 is negative, 2 is negative, AVF is negative. So again, it is a left axis deviation, very good. So coming to the chamber enlargement, so here we are seeing something. So it is called as an RS pattern. RSR in lead V1 is seen here. Also it is seen in V2. So this is suggestive of a right bundle branch block pattern. Okay. So the final diagnosis is very simple here. So we have a Mobius type 2. AVR is negative. Net AVR is negative. Or maybe it is equiphasic, you can tell. So this and this is equal. It's fairly simple. So it is Mobius type 2 A block with a right bundle branch block. What is important here is whenever you have a Mobius type 2 AV block, it is an indication for a pacemaker implantation. So that is what it is important for. Why should we even try to diagnose this is because this Mobius type 2 will progress into complete heart block very soon. That is why it is mandatory to put a permanent pacemaker for such patients. How would I say RBBB? Someone has asked me this. So whenever you have an RSR, so whenever you look for to make a diagnosis of RBBB or LBBB, it is fairly very simple. So you look at only 2 leads. You look at lead V1, you look at lead V6 and lead 1. So they look at 3 leads actually. Okay, so in V1, you will get an RSR usually in V1 in right bundle branch block. So which we have here. Then we look at the S wave in V6 and lead 1. So it will be a little wide. So there is a nice S wave here. This is not there. So this is, we'll discuss this subsequently. This is what is called as a masquerading bundle branch block. So we'll have a separate discussion on this masquerading bundle branch all in our advanced course or advanced section. So you should have an S wave ideally in a patient with a right bundle branch block. Along with that, so S wave here we are seeing some amount of S wave, but it should be very wide in lead V6 and lead 1. So that is about right bundle branch. So in left for diagnosing a left bundle branch block, so you will have QS in V1 to V4. Along with that, you will have a nice R wave in lead V1 and V6. So these are the only things. So whenever you are thinking of a bundle branch block, so you look at this. So whenever you have an RSR, so you look at lead 1. So when you have an S wave, so you call it as a right bundle branch block. Simple. Okay. Clear? Yeah. Cool. Okay. So can you tell what? So can you try this one? What bundle branch block this is? It's going to be an RBBB or LBBB. This ECG here, you're seeing here, no? This is RBBB or LBBB. This is RBBB or LBBB. So in V1, in V6, in lead 1 we will see. V6 here, it's negative, that's okay. In V1 here you're seeing, correct, someone says LBBB, LBBB, very good, very good. So this is a left bundle branch block, very good. So you're seeing QS complexes all throughout. So in V1 you have a QS complex. And in lead 1 here you have again a nice R wave. You see here, very nice R wave here. So this is what I call. So only these two leads, V1, lead 1. With these two leads you will diagnose. So there is a QS in lead 1 and with all R wave in lead 1. This is equal to a left bundle branch block. Okay, done. I'll just tell this, since I made a passing comment. So whenever you have an RBBB, you should have a S wave here in lead 1 and lead V6. Okay, if the S wave is absent, that means there is an advanced left bundle branch that is being hidden. So that is why it is called as a masquerading bundle branch block. That means the RBBB is hiding an underlying, it's usually a left anterior fascicle that is going to be blocked here. So whenever you have a coexisting, so you will have the S wave that is going to be lost. Whenever there is S wave lost, RBBB with a loss of S wave with a left axis deviation. So you should think that there is an advanced, so this essentially means there is an advanced conduction disease. So you leave for some time, patient will go into complete heart block very soon. There is all evidences for a complete heart block going into complete heart block. You have a Mobius type 2 here. You have this very peculiar masquerading, what we call as masquerading bundle branch block. All that is, it will make sure that the diagnosis is an advanced conduction disease. Okay, so we have RBBB Mobius type 2. Okay, so yeah, this is very simple. So you can just put your comments on what findings you are finding. I'll just wait for your comments and then we'll discuss it. So what findings you are seeing here? We can put one by one. Improper lead placement. Okay. Good. So someone says it's a normal sinus rhythm. Very good. Excellent. Excellent. Someone says septal STEMI. You have a septal STEMI, that means, so whenever you have an R wave, that means the muscle is very good there. So here you are having very good muscle here. So if the R wave is lost, that means the muscle is lost there. Good, good, good. So major findings have been told. Excellent, excellent. Okay, anyone wants to tell any hypertrophy chamber enlargements anyone wants to comment upon? Okay, so normal standardization and normal sinus rhythm. So coming to the rate. So the rate, let's say it's a little difficult here. We don't have the boxes very clearly defined. Let's say so this should be somewhere around. So there is some amount fairly regular. There can be some mild change. So up to 3 small squares change can be there in the RR interval. That is normal. Okay. So we'll start interpreting this. So there's a normal sinus rhythm, normal standardization. The P waves are upright in 2, 3, and AVF. And coming to the heart rate, let's say it's somewhere around 70, 75. Okay. So coming to the intervals. So the intervals look fairly okay. The P wave, we come to the P wave. P wave is there. The QT interval is okay. You can use somewhere, so there will be QTC that will be given. But it's always better to calculate. Many times this QTC will be wrong in the system. So that is why it's always better to always calculate it. Okay. So I'm coming to the axis. So coming to the axis, so you see lead 1 is negative and lead AVF when you're seeing. So it looks a little biphasic. So it looks biphasic. Or some parts of it are hidden inside the previous QRS. So you can call it as a right axis deviation. So if you take the degree somewhere, it will be somewhere almost horizontal here. Okay. So this is almost like severe right axis deviation. Okay. So there is a severe right axis deviation that we are seeing. So coming to the chamber enlargements now. So when you're saying chamber enlargement, so anyone thinks any chamber is enlarged? Or there is no chamber enlargement? Yeah, I will tell you why it is positive. Yeah. Any chamber enlargement you're seeing? So someone had mentioned R base is more than 1 in V1. Correct. Very good, very good. So what does it indicate? What does it indicate? R base more than 1? Excellent, excellent. This is suggestive of a RVH. Very good. Very good, very good. Excellent, excellent. So this is suggestive of a RVH. So there is a right ventricular hypertrophy. So that is why we are having a right axis deviation. So whenever it is very severe, then you can have this amount. Sometimes the AVR may be having this R wave positivity. So apart from that, so you have a very tall R wave in lead V1. So this is classical for a RVH. So you should not have RSR like this. This is not RVH. It's only tall R wave like this is suggestive of an RVH. Okay, here if you see the S wave also here. So either you can have a very tall R wave here in V1, or a very nice, very big S wave in V6. Both are suggestive for an RVH. If both are more than 7, you can remember that isolated R in V1 more than 7 or S in V6 more than 7. Both will be suggestive of a RVH. Okay. So this is also a similar ECG. So this was a 17-year-old female who presented with worsening exertional breathlessness. It was a young patient. So we wanted to, so here you are seeing what are we seeing on the ECG. So assuming the standardization is normal and the rhythm is sinus, so we look at the deciphering what are the other things, very important findings. So the P wave here looks okay. Here you have one is negative, AVF is positive, so we are having a right axis deviation here. Correct. So we are having a right axis deviation. Apart from right axis deviation, what else is there? So coming to the chamber enlargement. So we'll discuss only some 4 or 5 points. So whatever we have discussed in the previous classes only. So coming to the chamber enlargement. So this chamber enlargement we are seeing again in V1 the R is more than 7 millimeter. Again S here is very deep. So both are there. Yes, correct. RVH, very good. There is RVH, excellent. So there is RVH. Okay. So this patient also had some irregular cycles. The thyroid function was normal. Some skin changes were there. So they thought of connective tissue disease. ANA was not worked up. But then very important is whenever you're having a young patient presenting like this, you also have to look at the valvular lesion. So here the echo is normal for valvular lesions. So they made a diagnosis of primary pulmonary hypertension, which is common with many connective tissue diseases. Okay. So we have a right axis deviation, the R in V1 more than 7, S in V6 more than 7. So finally I was diagnosed to have primary pulmonary hypertension. I think I have two more ECGs and we'll be done. Anyone wants to try this? This is simple. You can go for it. Anyone wants to answer? Volunteer? Extreme axis. That's why always you should have a correct. So extreme axis is present. Correct. Good. Then always have a methodical approach. You will get the diagnosis. That's why the aim of all of this is to make you think in a methodical way. So you look at this, then you look at AVR. The first thing is you look at AVR. So you see, so AVR is positive here. Once you see AVR is positive, look at the R wave progression here. So there is reverse R wave progression. AVR is positive. What do you think of? Yes, correct. Dextrocardia. So here you have R positive, 1 is negative, AVF is negative. So there is an extreme axis with an extreme axis deviation with a reverse R wave progression or poor R wave progression. Think of dextrocardia. Okay. So how do we just a summary of again what we had discussed. So AVR is positive. So either it can mean there is a lead reversal or there is dextrocardia. So you just look at the R wave progression. R wave progression is abnormal, dextrocardia, normal R wave progression, lead reversal. So to identify which lead is wrong, so if you see this is my left arm, this is my right arm, this is my left leg. This is going to be my lead 1, this is going to be lead 2, this is going to be my lead 3. Okay. So now if I've changed the lead placement, so what will happen is this is going to be my left arm, this is going to be my right arm. The left leg remains the same, assuming that they're not swapped that also. So then this is going to be negative lead 1. Correct? So this is going to be lead 1. Left arm and left leg is lead 1. Right arm and left arm is this is going to be lead 3. Sorry. So if I'm going to make a new placement, so we'll see which lead is going to be unchanged and in which of the leads what we are going to see. So here you are seeing this is going to be lead 3. So my lead 2 will become lead 3. So the right arm and left leg, which is going to be lead 3, will be equal to lead 2. And this lead 1 will become inverted. So this is how you think. So if you want to look at lead 2, it is actually lead 3, which is going to be lead 2. So you look at that and you can make some conclusions as well. I think this would be last year. Any takers for this? Any attempts? You look at lead. So you can tell the findings that you are seeing here. You can answer in the chat otherwise. Good. So someone says there is a normal axis. Okay. So someone says normal axis. Okay. There is an M pattern. So someone says there is an RBBB. Okay. M pattern where? In which lead there is M pattern? That M pattern should be there in lead V1. Okay, I'll summarize the whole thing. Yeah. At the end, I'll summarize everything, whatever we have discussed. Okay. Yeah. Oh, what about P wave here? Anything in the P wave? Yeah, correct. So this is LA enlarged. Okay. So there is LA enlargement. Why? Why LA? Why not RA? Which chamber is enlarged? So when you're looking at the P wave, so you're going to comment on the atrial enlargement. So which chamber enlargement is going to be there? Here. P mitral is notched. Okay. P mitral. Notched P wave. Correct. So there is a notch. Very good. Okay. Fine. See, a normal P wave here should be more than 2.5. It should be less than 2.5 millimeters. So here, if you see this P wave here, it is more than 2.5 in height. So the height here is more than 2.5. If the height is more than 2.5, what does it indicate? Here you're seeing the height. See here, 1, 2, 3. So almost it is 4. So what does this indicate? So the first part of the PV is going to be the right atrium activity. Second half will be the left atrium. So if this is going to be enlarged, so it is going to indicate right atrial enlargement. Okay. So there is a tall P wave here. So the tall P wave. So whenever you have a height that is enlarged, this is going to be a right atrial enlargement. Okay. Okay, fine. Yeah. So this is right atrial enlargement. Sorry. So this is going to be my right atrial enlargement. Here you look at the P wave here, the negative portion here. So this is my left atrial enlargement. So that is why whenever you look at the P wave, always look in two leads. Look at lead 2 and look at V1. Because see, sometimes you're seeing only this portion here. So this notching, no? So if there is a notch, then it indicates probably there is a biatrial hypertrophy, biatrial enlargement. So this is also very important. So when there is a notch, then you also think of a biatrial enlargement. Okay. So only notching if there, then you think of a left atrial enlargement. But here you are having also the height that is increased. So you have to see everything. So you have to see everything together. So there is a height that is increased, the width that is increased. So there is a biatrial enlargement. Okay. So that is why always P wave you look at both lead 1 and V1. So in this you look at both the initial component and the terminal component. Here you look at the height and the width. Sometimes one component will be visible here and the other component will be visible here. So that is why for looking for atrial enlargement, you have to look at both the leads for atrium. Apart from that, you are going to have some part of the criteria that is fitting for the LVH. So you see here, like, this part of is actually cut off. So this is a part of it is here. So you can see very wide, very deep S waves and somewhat tall R wave in okay in V5, V6, so it is normal in V6, but the S wave is very deep. Okay, so this was an actual patient of a hypertrophic cardiomyopathy. So this patient had this biatrial enlargement. So whenever you have this cardiomyopathy, usually this biatrial enlargement you'll see many times. Okay, so this was the final diagnosis. So there is a biatrial enlargement with LVH. Okay, so I think that is the end of this today's session. So summarizing whatever we have discussed in these two sessions. So we look at the standardization first. So look at the paper speed and the amplitudes. So once we have finished that, we look at the rhythm, whether it is sinus or not. Then we look at the rate. So here whether it is regular, irregular, and normal sinus rhythm. Then the rate, so whether it is less than 100, more than 100 or less than 60. So whether it is a tachycardia or bradycardia, and how to calculate whether it is regular or irregular, how to calculate heart rate. Then you go to the intervals. So you look at the PR, QT. Then the axis. So we know for a right axis deviation, lead 1 is positive. Lead 1 is going to be negative. So for a right axis here, so lead 1 will be negative. Lead AVF will be positive. So there is a right axis deviation. For a left axis deviation, 1 is positive, AVF is negative, and also lead 2 will be negative. Then it is a pathological. If the lead 2 is positive, that means it is a physiological left axis deviation. Once you finish the axis, we'll come to the chamber enlargement. So chamber enlargement, very simple, only two chambers that are there, atria and ventricle. For atria, either it is right atrial enlargement or left atrial enlargement. So if it is right atrial enlargement, the height will be more than 2.5 in the limb leads and more than 1.5 in the precordial lead. Same thing here. So the width here is more than 2.5 and the negative portion. So this is the first portion, this is the second portion. Usually it is biphasic in V1 to V3. So this portion will be wide and deep. So this is left atrial enlargement. So if you have to come to the ventricles now, so whether you have an RBH or an LVH. So the R by S is more than 1 in V1 or the S wave is very deep in V1. So that is suggestive of an RVH. In LVH, S in V1 or 2 and you add the R in V5 or 6. If it is more than 25, it is suggestive of a left ventricular hypertrophy. There are also many other criteria. I think this is the most commonly used and I think we'll stick to this. Okay, so I think this we have finished. I just told briefly about bundle branch block. So I'll just mention it. In subsequent classes, we'll see why each pattern is generated. What are the implications of all of that? So I said you look at lead V1 and lead 1. So in V1 you get an RSR. Here you get a QS. And in lead 1 you will get a wide S. Here you get a monomorphic R. So that is about bundle branch block. That's it. Okay. I think we have summarized enough. I think I've told some of the points that may be useful. Okay. Any questions that are there? Any questions? Okay. No questions. Any doubts? Nothing. Okay. Anything you want to ask? You're free to ask. And if you have any interesting ECG that you want to discuss or something, you can just bring it up or you can share it on the email and in the next session we'll take it up. Okay. So the next session will be on next Sunday. So it will be on arrhythmias. So the common arrhythmias that we are going to see. So atrial fibrillation and PSVT and ventricular tachycardia. So these three arrhythmias we'll be covering in the next class. Okay, the class will be by Dr. Anil sir, HOD and Professor of Medicine. Okay. Thank you and happy weekend. I'll end the session.